Hello everyone. Today in our podcast series, today is our fourth podcast, and today we have invited Dr. Srikar for talking on the topic of analgesics and sedatives used in our ICU setup. So I'd like to first welcome him to our podcast. Welcome, Dr. Srikar.
Thank you.
So today our topic of discussion is use of these analgesics, sedatives and various neuromuscular blockers in our critically ill patients. So we'll be starting on this topic proper. So let's move to our topic. So why do you think these sedatives, analgesics are required in our patients? Is there requirement of using sedatives? We don't use in ward most often. That's why I am asking you.
In the ICU setup, due to the ICU setups are often stressful to our patients, particularly because of the procedures that are done on the patients, or even the routine care that is given in the ICU for ICU patients is quite stressful for them. So as intensivists, we aim to minimize the pain and discomfort of the patients. So for that reason, we use analgesics and sedatives.
Yes. So those patients are not able to communicate more often, like if intubated, and they won't be able to tell you if they have pain or not, or any, and they will just only show you signs, and you have to observe that to interpret those things.
Yes.
And there are a lot of beeping noises in the ICU, so those also makes people uncomfortable when they first come.
Monitors.
Yes.
The lights near the patients. These all disrupt the patient's normal sleep wake cycles and make it all a very stressful environment for the patient. Yes.
Yes, and also there can be might be different fluctuating level of consciousness.
Yes.
So to address all those parts, is sedatives and analgesics important? You mean that, right?
Yeah.
Okay. So now talking about pain, how do you assess pain in your patients? Because intubated patient won't tell you that I have pain. So what are the scales do you use in those patients, and on patients on NIV or on general face mask or nasal cannula?
So if the patients are intubated, we obviously cannot ask them if they are facing some pain or anything like that. So we use a behavioral pain scale as mentioned over here. A scale anything up till 5 is adequate for pain control. We take it as yes, the pain has been adequately controlled. More than 5 means that our whatever we are giving for pain management is not adequate, and we have to step up our management accordingly. So this has three components. First is we will just look at the patient's facial expression as to how he is reacting when we are observing him. Then we also look at as to how the patient's upper limbs and how the patient's trying to move his arms. Like in the facial expression, we assign a score of the lowest score 1 to a relaxed patient, and a patient grimacing, that painful that very pained expression, we give a score of 4. Then we observe the upper limbs also. For a no movement, we give a score of 1, and if the patient is in pain, he'll obviously flex his limbs towards the painful side.
Yes.
Hence we say that yes, the patient is fully bent, his upper limbs are fully bent, fingers are flexed or permanently retracted.
Right.
Because so that's a useful behavioral scoring point to note for the pain present. Then another thing is ventilation. This is not the operating theatre where where we are giving say a gaseous agents like propofol or whatever. Here it is just that medical air and oxygen. So, these patients of course, in the operating room also you have to be careful in manipulating the ventilator settings. These patients we should if they are finding it painful, they will obviously start struggling or struggling or fighting against the ventilator.
Yes.
So, that is also a point to be noted. That is also we also use this fact of compliance with ventilation in our behavioral score.
Yeah. So, basically you told you look for face, you look his upper limb, and you look whether patient is fighting with ventilation,
Yes.
coughing or not tolerating or not, right?
Yes.
And if we get 5 is the cutoff, and if 5 or less, it means that he has adequate pain control. Okay. And this is for intubated patients, and you can you tell about for non-intubated patients what kind of pain scale do you use?
We use for non-intubated patients, say if they are on a nasal cannula or a face mask or a venturi mask, we use the NRS scale. We ask them, we give them, we explain to them a scale of 1 to 10, where 1 is the lowest score and 10 is the worst pain they can imagine, and we ask them to give a numerical rating of their pain.
Okay. So
3 or less than 3 means it is well controlled.
Okay. Nice. Now, assessing agitations in our patients.
Yes.
So, which scale do you use?
We use the Richmond agitation sedation scale.
Okay.
It comes pre-printed in our ICU chart.
Yes.
So, it is quite handy.
Yeah, I have seen that.
So, we usually our target is to maintain the patient either calm up to light sedation is acceptable.
What is the definition of light sedation? What kind of sedation do you mean by that?
That is, if you just call the patient and just gently tap him, he'll just wake up. He'll wake up and look at you.
Yes, he opens his eye and the contact remains for less than 10 seconds with the provider, with the healthcare provider.
Yes, he'll briefly look at you when you just touch him gently and call him.
Yes.
Eye contact less than 10 seconds.
So, you mean in this scale -1 or -2 is good enough?
-1 or -2 is decent, yes.
Yes, and about 0?
0 is the ideal.
Yeah, that is not possible.
It is possible, yes, but it's not. It's unlikely that the patient will remain 0 throughout the day or 24 hours.
Okay. So, you have to lightly sedate as well because of these things, many things in the ICU room, this beeping sound, this discomfort that patient is having, the pain. So, rather than 0, -1 or -2 is good enough, right?
0 to -2 is good enough.
0 to -2.
Yeah.
Okay. And we talked about analgesics, I mean pain, assessing pain in ICU patients. We talked about assessing agitations with this sedation scale, and delirium I also see very often in the ICU setup. The change in the baseline state of consciousness patients, particularly elderly patients who are shifted from nursing home or who have chronic comorbidities like COPD or heart failure or chronic liver disease, chronic kidney disease, patients are on dialysis. Those types of patients are prone to getting delirium more often than younger, healthier patients.
Yes. Yes.
And what kind of screening tools do you use to assess delirium? Because I have read that if you don't screen for delirium, we missed 3/4 of the time.
Yes.
Yes.
In our setup, we use the CAM ICU score for screening for delirium. The CAM ICU is a it is a more of a flow sheet for assessing the delirium, for how the delirium status of the patient. Firstly, we assess if the patient's mental status has changed since before, since his or her baseline. Then after that, we assess if the patient is having any problems in the focusing his or her attention. For that, we use a test, like we ask the patient to squeeze our hands when we are spelling out a word, and we tell them to squeeze their hands when they are given as when certain letters come, like Casablanca. When we are spelling CASABLA, we keep tell the patient to squeeze our hand when when an A is encountered.
Yes.
So well, for if they are more than two, less than 2 or less than 2 errors are tolerable, and we can say the patient does not have delirium. Then if they are more than 2 errors, then we have to see assess the his status in the RAS scale. If the RAS is not equal to 0, then the patient, we classify that the patient has delirium. Then if the RAS is 0, then we have to then we assess for disorganized thought. When the patient's thought process, we first it has 2 components. We ask the patient simple questions, like does a stone float on water, or are there fish in the sea? If they are more than if there's 1 error, it's still acceptable. If there is more than 1 error, then the patient definitely has delirium. And then we try to make the patient follow simple instructions, like the holding up of 2 fingers, making the patient hold up and then telling the patient to follow. If the patient is not able to follow, then yes, we classify that according to this code the patient has delirium.
Yes.
And once the patient has got delirium,
so in this also you can allow 1 error.
Yes.
Right? Yes.
Now once the patient has once the patient has has been assessed to have delirium, we should promptly rule out the various factors that could be causing it, like any organic factors like electrolyte abnormalities. Are we using then are we giving any particular drugs that could cause delirium, like particularly if we are using benzodiazepines. These are very deliriogenic drugs, frankly deliriogenic. And even ketamine causes delirium on emergence. So, or is there any lack of if the patient hypoxemic, or is the patient patient constipated, or is there any problem in voiding urine?
Yes, urinary or fecal problems. I think
yes. We have to assess and rule out all the factors.
So obviously there are multiple etiologies of delirium. So we should not incriminate the ICU setup only as delirium, but we have to exclude various causes, like you told, from drugs to infections, variety of infections. Patient might go in sepsis, toxins like uremia, hepatic encephalopathy, those various nitrogenous toxins, and
pulmonary
pulmonary conditions, chronic pulmonary conditions, or acute pulmonary embolism, myocardial conditions like myocardial ischemia, acute myocardial ischemia. So basically there are multiple etiologies that the basic concept is that whatever the either maybe electrolytes or oxygen or whatever nutrients, low glucose or whatever that cell requires to function. If that you disrupt that cell, neuronal cells, then there is obviously alteration in the conduction of that cell, and that causes the change in the baseline state of consciousness, right?
Yeah.
What I understood from you that
yes,
I understood rightly. Okay. So we assess delirium, and now let's start. So we talked about pain, agitation and delirium. Now let's talk about regarding pain management. So which analgesics do you use in your patients for pain management?
In our setup, we use pain management, especially as an anesthetist and intensivist. There are two components. One is opioids and non-opioids. The non-opioids are used for as a part of multimodal analgesia for their opioid sparing effects. So in the opioids we use fentanyl. Most commonly, fentanyl is both a sedative and analgesic. We can we can use morphine also, in particularly in surgical patients who receive it via epidural. Then occasionally, if morphine is not available, we use ropivacaine as an epidural for epidural analgesia.
So if morphine is not available, then only you go for ropivacaine, which is a local anesthetic, I think, right?
Yes.
That is disturb the conduction of sodium channels of the neurons. Yes. So fentanyl, you rightly told that it is both sedatives and analgesics. So you don't have to give sedatives if you give fentanyl. Do you mean to tell that?
We have we occasionally given midazolam, benzodiazepines with midazolam with fentanyl. But that was particularly in cases where deep sedation is required.
Like for example,
neurosurgical cases most commonly, or in certain ARDS patients.
Or you have to lower down the ICP of the patients.
In particularly in the neuro patients, you have to keep the ICP low.
So sedatives also help to lower down. In that case, deep sedation is required, and in this condition you combine. Otherwise, generally we don't combine fentanyl with other sedatives, right?
Generally,
in most of the conditions.
Generally, we try to avoid that benzodiazepines.
Yes, because you told that it is deliriogenic. It can cause delirium and other lot of side effects. It can cause post effect, like you have difficulty in a spontaneous awakening trial. Okay. So in ICU, I have also seen a lot of patients with because they have some patients are in sepsis, already prior comorbidities like hepatic derangement, renal derangement. In those conditions, also you have to modify the dose of these analgesics, or you have to certainly avoid.
Which is particularly paracetamol. We avoid it particularly in the hepatic cases, liver failure cases.
In NSAIDS we avoid in renal failure cases. In those cases we can go for opioids like fentanyl, like those things. Okay. Now about sedatives, which sedatives do you use more often in your practice?
We use in the cornerstone of our practice in sedation are fentanyl and dexmedetomidine. And after that midazolam also. So
dexmed, fentanyl and midazolam. But midazolam is less preferred, right? And but we can also use propofol, ketamine, depending upon the scenario, right?
We can use it depending on the scenario. Propofol is the main dexmedetomidine is nice because it doesn't cause that respiratory depression, and when most of the ICU patients are on the ventilator, and our main aim is to liberate them from the ventilator as safely and as soon as possible.
Yeah.
So, dexmedetomidine is ideal in a way. Dexmedetomidine and fentanyl are good in this aspect. Propofol and midazolam have the propofol causes outright apnea.
Yeah.
Midazolam causes respiratory depression. So, we don't so it's I feel I occasionally do feel hesitant about apart from about using propofol in particular.
Okay.
Then midazolam I have already mentioned that it causes in delirium for these patients.
Yes, but in some patients like alcohol withdrawal, we can consider benzodiazepines.
Yes. We definitely use benzodiazepines for
lorazepam as well.
Yeah, for those patients as well.
So, we have to see the hemodynamic status of the patients before we choose sedatives. Like if patient is hypotensive, then obviously ketamine will benefit.
Yes.
If patient is bradycardic, then ketamine will benefit. If patient has COPD with asthma, bronchospasm, then it helps to relieve those because it has bronchodilator effect. So, we can consider ketamine in that cases. But if patient is bradycardic with patients with AV block, heart block, in those conditions we avoid dexmed.
Yes.
And if we start dexmed and if heart rate begins to fall down, then we titrate it down, and even if it is not controlling, then we have to stop it, right?
We stop it initially, and then we titrate.
Okay, we slowly titrate.
We slowly titrate it.
Okay. And now you told that benzo causes delirium.
Yes.
Benzo causes delirium, and delirium also requires sedatives.
Yeah.
Because to calm down the delirious patients, you need sedatives, and sedatives cause delirium. So, this is the circle, I think.
It's a vicious.
So, how do you balance this?
We balance it by we first rule out, try to eliminate all the other factors that could have caused delirium.
Yes.
We try to rectify those factors. Then after that we avoid the use of benzodiazepines.
Yeah.
I have already mentioned other sedative agents that can be used. Then then the patient then after that we basically try to liberate the patient from the ventilator as well.
Yeah. And try to shift as possible to what?
Yeah.
And we also need to encourage those family members visiting.
Yes, we should also the family members should also have a more active role in spending time with the patient.
Yes.
It will definitely help in reducing this the delirious episodes.
Yes. And I also heard previously your experience that you told about one mute girl that she was not able to communicate and you were not able to assess properly. So, we have to also assess whether patient has hearing impairment or vision impairment or a speech impairment. So
that you don't falsely report that the patient is in delirium.
Yes, and also we can support, like for example, if patient has minus power or plus power and he is not using spectacles in the ICU and he is not able to see properly, but if you give their vision aid or hearing aid, that also helps to improve the if for example patient is using hearing aid in the home, but in the ICU you may not be using. So, if you give them that, then he will be able to better recover from that delirious states. So, that is also I think important.
Yes, that is also important.
Okay. Now, what about these drugs like olanzapine, risperidone, quetiapine, haloperidol? Are there any sedative role of these, or for what purpose do you use in the ICU? Because I have heard your experience about use of quetiapine. And you also told that previously you had told me that haloperidol you use in agitated patients, right?
Yes, yes.
So, would you please shed a light on this?
Haloperidol, yes, we use haloperidol particularly in that if the patients are very aggressive and need sedation at once, we use haloperidol. The one place we avoid using it is if they have increased conduction times in the ECG.
Okay. So we mean QT prolongation.
QT prolongation.
So these drugs are notorious to cause QT prolongation.
Haloperidol in particular.
Yeah.
Then olanzapine. Then we have used quetiapine, particularly in cases where we could not reduce the delirium by other means.
Yeah.
We put that patient on quetiapine.
And that patient was able to recover in 48 hours, right?
Yeah, after 48 hours she was less agitated than before.
Yes, and you had tried other sedatives in that patients that was not able to relieve her delirium.
Yes.
Okay, so I think it is last resort.
Yeah, and then we had also brought along with our management with that patient was not just pharmacological. We also brought the patient's family to spend to be more involved with her in the visiting hours of the ICU.
Yes.
Spend a bit more time.
Yes, and regarding that part, I would like to also add one thing, because ICU, because this is like a sterile room and you don't allow much visitors to come more often, we try to avoid, and for prevention of delirium we have to encourage that part. So we have to finally balance, I think, these two parts.
Yes, it's we have to balance the risks versus the benefits.
Yes. And now we talked about these analgesic sedatives. Now the remaining part is about paralytics, these neuromuscular blockers. So when do you use these neuromuscular blockers?
Neuromuscular blockers we can use either as a bolus dose or in a continuous infusion.
Yeah.
Continuous infusions I have seen them used only in very sick patients. It's more commonly used in bolus dose in patients who are like we have ruled out everything, all the other possible causes, and the patient is still fighting against the ventilator and the oxygenation is being poor. So, so in such cases we can give, say, a bolus dose of a neuromuscular blocking agent while we try and work up the patient in the meantime.
Okay.
As to the cause of her fighting, and it would also give the patients some time to rest. That respiratory fatigue would be reduced, but
I think it has very short half life, and you can, I think, not more than 20 minutes you can with one just shot, I think.
It won't last long.
Yeah. So in the meantime, you will be able to identify and treat the underlying etiology. So for temporary, you give these paralytics, right?
Yes, temporary. And when we are giving paralytics, the patient, we should also ensure that the patient is having that we are planning to sedate the patient before we are giving the paralytics.
Yes.
Because giving the paralytics without sedation is a very traumatizing experience for the patient. This is not the OT where some isoflurane or sevoflurane is running. No.
I can understand it. So I think those groups of patients are already on those analgesic sedatives because you are considering paralytics. So I think those are
either very sick patients. They are usually if they need that paralytics, they are already very unstable.
Yes.
On multiple pressors and other infusions also.
Yes. So those patients are already on those analgesic sedatives, I think, right?
Yeah, they are likely to be.
It's
because the sort of patients I am talking about are likely to be on lots of this of other infusions and drugs as well.
Yeah, you told about vasopressors and multiple other. Yes. So which do you use, cisatracurium, vecuronium, or other?
Vecuronium, we like cisatracurium because its recovery is fast and the emergence from cisatracurium is smooth.
Yeah.
Vecuronium, it technically can be given as an infusion, but we discourage it because it is a neuromuscular blocking, because it is a steroidal compound and it causes prolonged muscle weakness.
Okay.
We want the patient to be mobilized and out and walking as soon as possible, and this conflicts with our goals. So, we avoid VEC infusions, VEC, that is vecuronium infusions.
And also I have read in my school days about this Hoffman elimination. So, it does not have to depend on the kidney or liver.
Yeah, cisatracurium is also nice in this way, that
it
does not depend on the kidneys or the renal or hepatic elimination.
Yes. So, that is also another good part about
Yes.
cisatracurium. Now, talking about a spontaneous awakening trial. So, you have kept patients on these sedatives, analgesics, and for a spontaneous awakening trial you have to assess daily. And so,
Yeah.
for that what will you do? You will stop those sedatives. How long do you stop?
We stop them at least for an hour. If there are benzos in the sedatives, we stop for 2 hours, and then we assess the patient's, if the patient can be awakened, the patient's awakening.
So, what is the RAS?
We prefer it from 0 to -2.
Yeah.
And we then we also prefer this we also then after that we have assessed the patient, we then do a spontaneous breathing trial.
Yes.
That is, we put the now the spontaneous breathing trial can be either via a TP, it depends on the ventilator model. Some ventilators have for some you need to put them on a T-piece with no support, or for some you need there is an automatic SBT mode.
So, our ventilators have a automatic, right?
Yeah, it depends.
In our ICU there are automatic modes.
They have ones for which you need a T-piece and ones that are automatic also.
And also there is pressure support.
Yeah,
we can
pressure
also
pressure. You can also consider pressure support ventilation a weaning or a trial sort of mode.
Yes. And nowadays there are various machine learning, and they automatically assess whether patient is able to wean or not, or whether patient is ready for a spontaneous breathing trial, and they automatically give that.
Yeah.
Rather than healthcare provider doing that, the machine automatically does that. Those types of machines are also available, I think, right?
Yeah, it would although it's not available in our setup, we have to take the decision ourselves.
Yeah, okay.
And I think they suffer from those sorts of machines, machine learning. They suffer from the basic condition is that before you can liberate the patient from extubate the patient, you should make sure that the underlying respiratory cause abnormality has been resolved.
Oh, yeah.
Yeah, and I do not think AI is that good enough that.
Yes, they are definitely the role of health provider comes.
AI is it's not good enough at even the because I have seen AI, plenty of research papers have come and gone, but when it comes to the commercial application, that is real life application, they always tend to fall short.
Yes, I think you raised a very important point, but another good part is that it has helped very lot as well.
It can help, yes,
but it won't be able to replace human. I think
it cannot replace.
Definitely. Now, summing up all those points, about the pain management, agitation management, and delirium management, and requirement of these neuromuscular blockers. And you told very nicely regarding the when to use neuromuscular blockers, and how to titrate up and down these drugs, and we have also have to take care of those side effects that drug may have,
Yeah.
and in which group of patients according to their hemodynamic status we have to choose analgesic, we have to choose sedatives, no? And also regarding choosing neuromuscular blockers, you rightly told about cisatracurium over vecuronium, and you also talked about this spontaneous awakening trial, and then you go for a spontaneous breathing trial with 3 types of modes that
with
you told.
various modes,
Yes.
various modes of keeping the patient we just vary in the spontaneous breathing trials. The goal is we keep the support as low as possible,
Yes.
either by TPs or that spontaneous mode, which is say pressure where we just give only pressure support, particularly in those nail cord ventilators, or in SBT mode, particularly if in the General Electric GE ventilators.
Yes. So, do you like to add anything further?
My concluding remarks would be that sedation is an important. My remarks to summarize this thing up would be that sedation, that ICUs are generally painful,
Yeah.
and for which the intensivist has to appropriately give appropriately dose the analgesics and gives sedation as appropriate. And we should also be careful in avoiding avoiding delirium in our ICU patients, and we should be and we can do this by our vigilance, by our frequent assessment, and our dealing with the possible etiologies as soon as they come up. And then we should and we should aim for our patients to be up and about. They should not be confined to their beds. So, for that end, we should frequently assess our patients, that patients' level of sedation, if they can and conduct awakening trials and spontaneous breathing trials.
Yes.
And while all at the same time assessing the status of their chest and hemodynamic status, so that they can be liberated from the vent and be mobilized.
Okay. So, nice to hear from you, Dr. Srikar, and you shared a lot of your knowledge, deep knowledge, and wonderful experiences that you got in your practice. And I think it will be definitely helpful to all of our viewers. And if you have any questions or any concerns regarding this topic, you can comment it down, and we will be happy to answer if there is on anything that have difficulty understanding. So, it was wonderful talking to you, Dr. Srikar. Thank you.
Welcome.